Hi, Nick. Welcome to the show. How can I help you?
Hi, how are you?
I'm very well, thank you. How are you?
Good. Um, so my so I'm out of state and I was calling in, getting updates morning and night, and then me and his family had a little argument, and they banned me basically from the hospital, from everything.
Yep.
Um, so all I know right now is lung infection. He's been in there for 2 weeks. He is on the tube still. It is not pneumonia. Um, they tried to get him off of the tube, and they just did it like cold turkey. They didn't wean him off or anything, and he freaked out, and his blood pressure went sky high, and they had to put him back on the ventilator with 100% oxygen. So that's why.
Okay. And therein, okay, thank you. And this is good that you're explaining that, because therein lies the answer why A, they can't extubate him yet, and B, why they probably haven't discussed the tracheostomy yet either. If he's on 100% of oxygen, it wouldn't be safe to A, extubate him, and it wouldn't be safe to B, do a tracheostomy. Do you know what
Well,
I mean when I talk about a tracheostomy?
yes, yes.
Right.
He actually right now is only on 40% oxygen.
Okay.
They
Okay.
got him down to 40%, but it's the lung infection that is making it difficult. But he is breathing along with the tube, they said.
Okay. So he's breathing, but he's not waking up.
Right, right. And yesterday he actually opened his eyes, and he opened his eyes, but he's not responsive.
He's opened his eyes, but he's not responsive. Okay. And they stopped sedation?
He's still no, he's still sedated.
Okay. Okay. And it's been 2 weeks now, has it?
Yes.
And there's nothing else besides the pneumonia that you're aware of.
Correct.
Okay. So if he's now on 40% of oxygen, right, that's one ingredient to um, that's one ingredient to do a tracheostomy, right? But there are other ingredients too. So, for example, he would be on a PEEP, and I don't want to get too medical here, but if he was on 100% of oxygen, there's a very high chance that he's got a high PEEP, right?
Yes.
And if oxygen is not less than 40%, and if PEEP is not less than 10, it wouldn't be safe to do a tracheostomy. So that's where the delay might be to do a tracheostomy, because I don't know how much research you've done, but after about 2 weeks of mechanical ventilation and the inability to wean, it is recommended to do a tracheostomy, if that makes sense. Are you following?
Yes, that is what I've been doing, a ton of research, of course. And that is, yes, I figured that was the next step, because 2 weeks is, I'm thinking at that point. But as far as I know, they have not mentioned that.
Right, right, okay. How long ago was it that he was on 100% of oxygen? How long ago?
I'm sorry.
You mentioned earlier he was on 100% of oxygen
Yeah, that was 5 days ago.
5 days ago. Okay, so now he's down to 40%.
Yes.
Okay, again, a lot of it depends now. What is his PEEP like? And if PEEP is less than 10 and oxygen is less than 40%, they should be getting very close of doing a tracheostomy, given that I'm hearing he's not waking up.
Okay. Okay. Now, you are not really for tracheostomy, correct?
Well, I tell you what it depends on. A tracheostomy can be a wonderful thing, right? And a tracheostomy has their time and their place. And a tracheostomy is also in the context of which country. I presume you are in the United States?
Correct.
Right. So I tell you why it really depends on circumstances and the country. So in countries like Australia or in the UK, a tracheostomy is often being placed with the goal to wean a patient off the ventilator as quickly as possible. That, I believe, is the original purpose of a tracheostomy, and that's a good purpose. In the United States, however, if your friend is going, if your fiance, I think it was, is going to have a tracheostomy, they will try and send him to an LTAC as quickly as possible. And I'm very opposed to that. I'm very opposed of a tracheostomy being used to send patients to LTAC. That is unique for the United States. Do you know what I'm talking about? Do you know what I mean by LTAC?
No, I don't know what Altec is exactly. I have
Yeah.
no idea.
Yeah, sure. So in the United States in particular, a lot of patients in ICU end up with a tracheostomy if they can't be weaned off the ventilator. They end up with a PEG tube, and then ICUs want to send them out to an LTAC. LTAC stands for long-term acute care facility. From my experience, it's not even the better version of a nursing home, right? And therefore, patients go to LTAC simply to save the health insurance money and to save the ICU, or to free up a bed in ICU, which they so desperately need, but it's not designed for clinical care. Then patients go to LTAC and then nothing's happening. You know, families get sold on LTAC where ICUs are saying, oh, your family member goes to LTAC, they're specialized in weaning patients off the ventilator. And I say, well, that's a whole lot of nonsense. Just look up LTAC reviews online. Just look them up. They're shocking. Absolutely shocking. We're getting phone calls every week from families in LTAC saying, please help me to get my loved one back to ICU. You know, they're finding out too late that it's all designed to save money, but not for clinical care, right? So that's the bottom line, unfortunately, you know, and that's why it's so important that families are informed about the next step. So I am not opposed to a trach. If the ICU where your family member is at, if they're using the tracheostomy to wean him off in the ICU, fantastic, job done, fantastic. If they are using the tracheostomy to send him to LTAC, ooh, red flags everywhere.
Okay. What? How do I find out what what the purpose of the trach will be?
Yeah,
What?
good question. Yeah, just by simply asking them, what's your plan? There's also what we've seen over the years, Nick, is we've seen a lot of bait and switch. So what I mean by that is, you know, again, ICUs are talking to families and saying, oh, you know, your family member should have a tracheostomy to wean your family member off the ventilator. That's great. That should be the purpose of a tracheostomy. But what they're not saying is, once they do have a tracheostomy and a PEG, I'll talk about the PEG separately in a minute, that the ultimate goal is to send them to LTAC, right? And that is wrong in my mind. That is absolutely wrong, right? So, but there is a way to potentially work around that we've found out through trial and error. So let's just say your family gets approached about doing a trach for your loved one, often they also ask for a PEEP tube, right? And our advice is tracheostomy, yes, if the patient gets weaned off the ventilator, you know, as soon as the tracheostomy has been done, because it is easier to wean off the ventilator with a tracheostomy than with a breathing tube after a certain period of time, i.e. sort of the 2-week cutoff, the 2-week mark. But do not give consent to a PEEP tube.
I just have one question.
Sorry, I didn't get that. You're dropping. Try again.
With the trach, is that for oxygen or is that just for food source?
Ventilator. Trach is just ventilation. Trach.
It's for ventilation. Okay.
So currently your loved one is ventilated through a breathing tube in the mouth that's going into the lungs, right? That's very uncomfortable.
Okay.
A tracheostomy sits in the neck, right? It sits in the neck, in the lungs. It's much easier to tolerate. Much easier to tolerate. That's why sedation and opiates can come off straight away, most of the time.
Okay.
Right? One of the reasons your family member is sedated and on opiates at the moment is because of the discomfort that a breathing tube is causing.
I get it. Okay.
Right?
Okay.
So, you know, and that's why I'm sort of saying you will, you know, I know for anyone watching, you sometimes may wonder if you watch my videos, are you for tracheostomy? Are you against a tracheostomy? And I go like, a tracheostomy is a wonderful thing for the right patient at the right time. Tracheostomy can be a terrible thing for the wrong patient at the wrong time.
I see. Okay.
Right? It's not a one size fits all. And because I have an international audience here, right? It is also dependent on the country. Yeah.
Okay.
Right. So, and I argue absolute no to PEEP tube in this situation. In this situation, not, you know, like I mentioned, if someone, God forbid, has a high spinal injury, has motor neuron disease, has cerebral palsy, has SMA, a PEEP tube is inevitable. But in your loved one situation, I don't think he needs a PEEP tube at this stage, from what you're sharing with me.
Okay. So with the trachea, then she has to have a PIC too. A PIC?
No.
Okay.
Definitely not here. So this goes even deeper. This goes even deeper now. So let me talk about the PEEP tube. So currently your loved one would most likely have a nasogastric tube, which is a feeding tube in the nose going into the stomach. They would get nutrition through that.
Yeah.
Okay. That's perfectly fine. It's a temporary device, and that's perfectly fine. Now, again, in the United States, this is very unique to the United States, right? When patients are or families are being asked to consent to a tracheostomy in ICU, they're also often being asked to give consent to a PEEP tube. I don't know whether you were here a minute ago when I read out the email from James, who talked about his mum having a PEEP tube and nobody informed him what it really is. I don't know whether you've heard me read out the email and comment on that, because that sort of illustrates the issue about a PEEP tube. So the issue with the PEEP tube is A, it requires surgery. It's sort of a minor surgical procedure, but at the end of the day, it's still surgery, right? And it gives health professionals a perception of, oh, this person will never eat and drink again because they've got a PEG tube, right? That is the perception, unfortunately, right? And no one will bother trying to wean someone off the ventilator, wean someone off the PEG tube, you know, to get them to breathe again and eat and drink again, right? Whereas if you keep the nasogastric tube in, the nasogastric tube gives the perception of it's a temporary device. We need to wean this patient off the ventilator, need to take the nasogastric tube out and start eating and drinking again. So, you know, a lot of what's happening in ICUs in the US in particular is based around the pathway the insurances have laid out. And the pathway the insurances have laid out is, well, a couple of weeks in ICU, if they can't be weaned off the ventilator, let's do a trach and let's do a PEG and let's send them to LTAC where it's much cheaper to look after them. But they're missing critical steps. The critical step that they're missing is, have we tried hard enough to avoid the trach and the PEG and wean them off the ventilator? So that brings me, again, in comparison to other countries, other English-speaking countries, Australia, the UK, but many European countries, LTACs don't exist, right? So the ICUs are under pressure to wean someone off a ventilator. They are under real pressure, and they make it happen most of the time. Whereas in the US, I believe there's complacency in ICUs now because they've got the LTACs on the other end. So it's a very complex, it's a minefield. It's a real minefield. You know, having worked in multiple countries, Nick, I argue in most English-speaking countries, Australia, the UK, New Zealand, Canada even, the number of patients with a PEG tube in ICU is minimal. The number of patients with a PEG tube in the US in ICU is huge, right?
Wow.
For no good reason.
Wow.
Right? The reason is to keep the ICU satisfied and keep the LTACs satisfied and keep the insurances satisfied. Well, what about patient outcome?
Right. They're not looking at that. They're looking at money side. They're looking at the.
They're looking at money side. It's shocking. It is absolutely shocking. You know, just this week alone, we helped 2 of our clients with our advocacy to go from LTAC back to ICU.
Oh, so wow. So wow. Good for you. Good for you.
You know, but that should never happen in the
Never
first
happened.
place.
It's
Should have never
right.
happened in the first place.
Exactly.
Right. So
Oh,
it
that's
is
horrible.
the system is flawed beyond anything that anyone can comprehend, I believe. You know. So, but at least you've now got an overview of what questions to ask. What I can see with the information you've given me, Nick, probably yes to a tracheostomy, probably yes to that, no to a PEG tube. Here is another thing that's important. We have found that if families stay away from giving consent to a PEG tube, let's just say a tracheostomy is needed, right? And the ICU is pushing you to do a PEG as well, well, just stay clear of the PEG. That in and of itself is often enough for patients to stay in ICU and not go to LTAC. And here's the reason why. Most LTACs cannot take patients with a nasogastric tube. They can't look after it, which should tell you everything about the skill level that you're getting there. It's non-existent.
Oh my gosh. Oh my gosh. Okay.
Right?
I feel like now since it's been 2 weeks, like he's overdue. Like they're probably already
Yeah,
thinking
it's
about
overdue. It's probably overdue.
right.
But But the reason he's probably overdue is simply his ventilation needs have been so high that no surgeon would touch him to do a tracheostomy. The risk of a patient dying on the operating table doing a tracheostomy on 100% of oxygen is too high.
Okay, I
So
see.
Right, it makes sense to me.
Okay,
That
makes sense.
it makes sense to me, right? They're erring on the side of caution,
Okay, okay.
most likely, right? Now,
How long how can a patient stay in the ICU for months or?
years. I've seen up to 18 months.
Oh my gosh. Okay, okay, okay. So no PIP, just no PIP.
Well. Look. The sooner your family member can get off that ventilator, whether with or without a tracheostomy, the better, right? Time is of essence. You don't want somebody to stay in ICU for 18 months, right? You don't.
Right. No, of course not. Of course not.
You know, but I'm just we're talking about extremes here.
Right. Okay. Now I guess they're just waiting for the infection to clear up, I guess. But keeping him on the ventilator, it's scary. I
It's super
read
scary.
yes, yes. And they can't. They're concerned a little bit about his brain activity as well, because when they took him off the ventilator, they were telling him, um, raise your finger or raise your foot, and he was too busy freaking out to be able to even do anything like that.
Yeah, that's and the reality is that most patients, when they eventually come out of the coma, they're confused, they're agitated, they're hallucinating. You know, unfortunately, a recovery process, what your loved one is going, it's not going to be straightforward. Very rarely is it straightforward. You know, so the next challenge lies ahead once he's off the ventilator.
Right. It's like a whole another big
And
obstacle after the
that's
ventilator.
right. That's right. And
Okay.
that's why timing is so critical.
Is
You know,
yes.
the longer it goes on, the higher the risk for complications, of course, you know. But, you know, on the other hand, a lot of patients have come through this fine as well, but it's a struggle. Let's call it for what it is. It's a struggle.
Right. Well, I'm gonna be there for him. So we'll get through it. We'll get through it. Just yeah.
And that's the right attitude to have, you know, that you will get through it. And it's one of the biggest challenges that I believe families can ever experience. You know, it's terrible. It's not for the faint heart.
This is literally the scariest thing I've ever been through. And like I said, I'm not even in the same state, and it just makes it. It's yeah. It's horrible, but
Of course.
I appreciate you so much. I binge watched all your videos, and I can't believe I caught you live right now. It was meant to be. I truly appreciate your time, and thank you. Thank you so much.
It's a great pleasure. All the best to you and your family, Nick.
Thank you so much. You have a good night.
Same to you. Thank you.
Thanks. Bye bye.